Hello, everyone, and welcome to the Blakely Health Innovation Talk, Changing the Paradigm of Pain Management, brought to you by the UHN Foundation. I'm Christian Cote, host of the broadcast Behind the Breakthrough. It's all about groundbreaking medical research and the people behind it at the University Health Network, Canada's largest research and teaching hospital. We're grateful to you, our family of supporters, and so glad you're able to join us today. We hope you're staying safe and taking care of each other during these challenging times of the COVID-19 pandemic. We want to point out today's live stream is made possible thanks to the generous and ongoing support of Mr. Robert Blakely, a former board member at Toronto Rehab and the sponsor of this event. So the UHN Foundation would like to extend a special thanks to Robert. Today on the broadcast, we have the amazing research and innovative treatments being pioneered by clinicians and scientists at UHN's Toronto Rehabilitation Institute Research Center called KITE, and that stands for Knowledge, Innovation, Talent Everywhere. Today, we're focused on pain treatment, specifically chronic pain. And one of our KITE clinician scientists' groundbreaking treatment that is helping patients get off powerful opioid medications and living healthier lives. We'll also bring you an inside look at how clinical practice is evolved, particularly over the last couple of years during the COVID-19 pandemic. As well, we want you in the audience to get involved in today's conversation. So if a question comes to mind while we're talking to our doctors, please just go to the Slido page. The link is at the bottom of your screen. Click on that link, type in the event code, and submit your question. And you can also vote up questions you'd like to hear answered. Keep in mind, we can't, for privacy reasons, answer questions of a personal medical nature. And we'll take your questions a little later in the broadcast. Up first, Dr. Andrea Ferlin. Dr. Ferlin is an award-winning senior scientist at KITE, a clinician at Toronto Rehab. Her research is pioneering the study of chronic pain, including the concept of Deprescribing and the 5 M's. It's garnered her international recognition for improving the lives of patients with chronic pain. Welcome, Dr. Ferlin.
Thank you very much for inviting me to be here tonight.
It's great to have you. Let's start big picture. We all have a pain system, and I know you liken it to an alarm system in our house that alerts us to threats. Talk to us about the role of the pain system in our bodies.
Yeah, thank you. So we have this alarm system installed in our body, like the same thing that we have an alarm system of our house. You want it to be alerting your body, your brain, when something is wrong. If you have an appendicitis, a bone fracture, an inflammation somewhere. So if the pain system is functioning normal, the brain will be alerted, something's wrong, and you need to take care of it. But this pain system can break or malfunction and be dysregulated. And in that case, we need to fix the pain system instead of trying to find what is wrong with that body part. So that's the main difference between acute pain and chronic pain.
Yeah, maybe actually, if you don't mind, a little bit deeper dive into the difference between acute pain and chronic pain, because that's critical to understand for our discussion today. So maybe you could walk us through the two kinds of pain.
Yeah. So acute pain is a normal pain functioning of the pain system. So if you put your toe or finger on fire, the pain system is functioning normal. There will be an electrical impulse that will alert the brain and alert the emotions, because pain has to be unpleasant. If it was not unpleasant, we would not go to emergency. So it has to be emotionally unpleasant. It's linked in the brain. And that's normal acute pain. So post-surgery, if you break a bone, if there is inflammation, swelling, that is acute normal pain. Now, chronic pain, then the injury or the disease already has healed, and what is left is this malfunctioning of the alarm system. So the source of the pain is still real. Don't take me wrong, the pain is very real. The person is not imagining it, but the source of pain is different. It's not now anymore in the toe or the finger that is on the fire, but it's in the pain system that is dysregulated. So we need to fix the pain system instead of trying to fix the part that looks like the pain is coming from here, but it's not. It's like almost like a memory of pain. It's almost like something that was imprinted in the pain system.
And Andrea, what's the scope and scale of chronic pain suffering in Canada?
Yeah, so it's more than we imagine. It's 1 in 5 Canadians. And the impact of this is huge for the workforce. A lot of people that stop working because they can't, because of pain. And the burden of chronic pain major, it's the major driver of this disability that we see. It's more than cancer, cardiovascular diseases, and diabetes combined. Because so some examples are chronic low back pain, chronic neck pain, fibromyalgia, neuropathic pain, migraines is a big driver. So all of these conditions are under the umbrella of chronic pain.
And how traditionally over the years and decades has chronic pain been treated?
Yeah, unfortunately, this concept that chronic pain is different from acute pain has not been taught in medical schools, in medical residency, in family medicine. So the problem is that a lot of doctors and healthcare clinicians, they still treat chronic pain as if it was an acute pain that just continues for a longer period. And that's not the same thing. The interventions that work for acute pain do not work well for chronic pain and vice versa. And if people try to use a lot of the same things that we use for acute pain, like opioids is one of them. Opioids work well if you have surgery and you had a cut or a fracture or an appendicitis. It works well because that's acute pain and the pain system is functioning okay. But if you try to give opioids to chronic pain, we now know that it makes worse. So that's the dilemma that we have. We need to keep this information, get this information out to a lot of clinicians, physicians, pharmacists, nurses.
I want to ask you then, is there a connection historically then between the fact that chronic pain not being well understood, that it's actually a malfunctioning of the pain system? Is there a connection between that not being well understood and the fact that there's been an increase in opioid prescriptions over the last couple of decades?
Yeah, that's one of the big drivers, right, of the opioid crisis, not just the only one. The other big driver was a lot of advertising to physicians that 25 years ago, there was a big marketing campaign saying physicians, chronic pain, you can eliminate if you give them opioids. But at that time, we did not know what we know today. A lot of research has been published in the last 20 years, 25, 30 years, showing that chronic pain is a different disease. Actually, the World Health Organization just adopted a new classification of pain, taking into consideration that now chronic pain is a disease itself. And so it's one of the drivers, this misunderstanding of what is actually chronic pain.
Okay, so let's start then, or dive into your pioneering work to treat chronic pain and help rewire a patient's pain system. Deprescribing. Let's start with deprescribing. What does this involve?
Yeah, so I get a lot of referrals here in our pain clinic of people who had been receiving opioids for chronic pain for 10, 20 years. And now they are questioned, should I be on these opioids? Their family physicians are questioning, or the patients themselves. So when they come to me, then we discuss this concept of deprescribing the opioids. We need to go very slow, because if we stop abruptly, they will have withdrawals symptoms and they will suffer unnecessarily. We can do this very slow. But then the next question that they ask me is, how am I going to treat the pain? Because actually, they come with these opioids and they're still in pain. So it's easy to confirm, actually, the opioid is doing nothing for your pain because you are still in pain. But then in order to treat their pain, we need to give them something else. And our philosophy here in the pain clinic is self-management for chronic pain. The main evidence that we have is self-management, teaching the person to take care of themselves. And for them to remember, I created this 5M because that's easy for them to remember. So I teach them the 5 M's are movement, any kind of movement. I don't like to use the word exercise because exercise is a kind of a routine established. You need to go to a physiotherapist or a gym. You don't need to, just move. Movement is retraining for the pain system. That's the first M. And then mind-body therapies. We need to retrain the mind and body connection. And that involves, there's so many different interventions that we can use for mind-body. And then we have manual therapies, like self-massage and things that they can foam roller, that they can apply pressure to the body, to the muscles. That's the third M. The fourth M is modalities like heat and cold and electrical therapy, things that they can acupuncture. And the last one that I tell that if the first four did not work, then we can go to medications. And the medications we use for chronic pain are different than the ones like anti-inflammatories, Tylenol and opioids. They don't work for chronic pain. So we need to use antidepressants and anti-epileptic or anticonvulsant medications.
Can you tell us what kind of results you're seeing when you begin to taper or deprescribe patients and then bring in your 5 M's?
Yeah, so not everybody will get exciting results. Some people will feel that they are not easy to deprescribe, and they will they will never be able to get rid of the opioids. But those who can, and I would say more than 50% in our clinic are able to slowly deprescribe. And with this 5, especially with the first two, movement and mind-body therapies, they tell us over and over, we hear this all the time, oh my God, I am feeling so much better. I can think better. I was like in a cloud all those years. I was not getting out of my house. Now I feel that I can concentrate on things. Even I got partners, husbands and wives and kids coming to the follow-up and say, what happened? You woke up my wife. Wow. He said, he woke up, she was always tired and in bed. She didn't want to get out of the house. Now she wants to go out and walk and go shopping. What happened to her? Like for 10 years, she was in a cloud. We hear this all the time.
What's the time frame, Andrea, for when patients might start responding to some or all the 5 M's that you put them on in terms of treatment?
It really depends. It really depends on how long they were on the opioids, and also what was the dose of the opioids that they were. And sometimes they are not only on opioids, they are on a polypharmacy. We call polypharmacy when there are too many medications. Some people, and I do a slow taper, very slow. I never go too fast unless if the patient really wants to go fast. I tell them for every year that you were on opioids, we will take 1 month. So if someone was 15 years on opioids, I will plan the taper or deprescribing for 15 months. Most of them are able to reach them that goal before. But we go very slow. So I don't want them to have withdrawals, because if they start having withdrawals, they want to abandon the deprescribing, they get discouraged. And I want to make sure we will get there. Slow, but we'll get there.
So you have to manage expectations. I'm curious, what kind of reaction do you get from people who have been able to rely, in some respects, that might be a false equivalency, but rely on medications and they just take a pill, as opposed to they have to be very active now and engaged in their own health.
I have so many stories. I could be here the whole night telling you stories. I can tell you, there was a young guy, he was between 20 and 25 years old, and he was on opioids for a car accident that he had, I think, 10 years before. And he was popping these pills, and he said, I don't want to take this for the rest of my life. So he came back and we talked about tapering. And then he came back and he said, I'm not taking anymore. And I said, already you did? You know how he did it? He downloaded an app that it was a self-hypnosis app. And he found, and he said, every time that I feel the urge to take that pill, I do the 5 minutes of self-hypnosis and it works the same thing. And he was able to taper his opioids just doing that. I have other patients that they say, when I feel like the urge to take my opioids and I know I should not be taking them, like popping pills, I go for a walk, I do a meditation, I walk my dogs, or I go to a dog park and I watch a movie, I get distracted, I do crafts. It's amazing when a person really wants and is motivated, they can do it. I'm just their coach. I'm just there to coach them how to do it.
What's been the reaction of the healthcare system?
Yeah, it's really good. A lot of people are, still not believing that we can do this. I teach a lot of family physicians and nurse practitioners all across Ontario and Canada. And I have lectures that I teach how to deprescribe, how to taper opioids, and I teach them how you motivate the person, because a lot of patients also, they don't feel motivated that they can do it, or they already tried to do it and they had such a bad experience that they don't want to try again. So in this case, what we do is a lot of education, I want to do a little bit of propaganda here. We wrote this book, My Opioid Manager, here at UHN, and people can download the PDF of this book for free. So we give a copy of this book to them and tell them, go home and read it. And when you come back, let me know what you think of this idea of tapering. And then I usually am on the phone with their family doctor, educating also the family doctor, because the family doctor will be the one who will be doing the prescriptions and lowering the prescriptions. And I tell them, I will guide you. I will be with you every step. And if we need to pause, we will pause. We don't need to follow the schedule like a recipe. We can optimize and we can individualize for each patient. So once I am on the call with the family doctors, they are really, they're encouraged, because they tell me, Andrew, I never did this. I never tapered someone. I'm afraid that this person will end up in emergency on withdrawals. So once I guide them, they feel more encouraged and supported, and they do it. And once they learn with one patient, then they feel that they can do it with many other patients.
You've been doing this combination of deprescribing and the 5Ms treatment for a number of years now, Andrew. Have you built up, say, a database or a body of evidence to be able to show people the results you're getting?
So I've been doing this. I was the leader of the first opioid guidelines in Canada. And so I've been doing this, working on the guidelines since 2008. Mm-hmm. And the guideline was published in 2010. And so since when I started working on the guideline, getting the guideline ready, I learned about deprescribing. So I've been doing this since 2008, a long time. And so the database that we have, we know how many patients are doing this. We're not doing a research project with this right now, but I have been participating with other groups that are doing randomized trials, and we are using meditation in one of the trials that we're doing right now for people who want to have an option to opioids. And the results will be published very soon. Hopefully by the end of this year, we will have one trial published, and maybe in 2023, we'll have another trial published.
That's fantastic. You talked about, the importance, part of your work includes also educating healthcare workers. Also, you created an app through KITE with your team. Talk to us about the app and what it does.
Yeah, so there are two apps, actually. So this opioid manager, hopefully you can see. This one, the book is also an app. So it's called My Opioid Manager. That's for patients. Okay. And there's the companion app. It's called Opioid Manager for physicians. And basically what the two apps they do is summarizing the guideline, because the guideline is how to apply all these recommendations to practice. And it's a very long document. So in order to summarize for clinicians and for patients, we did the app. We did the book. We also have a paper form of the opioid manager. And I do courses, and I do this ECHO project, which is this ongoing weekly sessions. What this ECHO session is, every Thursday, I'm in front of a Zoom call like this, and these family doctors, nurse practitioners, physician assistants, pharmacists from all over Ontario, they register, and they come, and each week we have one of them presenting a case, and they present the case not only to me, but to me and our interprofessional team. And then we spend an hour discussing that case And everybody learn. I learn a lot. I learn more than I teach during these echo sessions. We've been doing this since 2014. So it's very good for me to have an idea what's happening in primary care and for them to get some feedback and discussion on they present their most challenging cases, the ones that they are stuck and they don't know what to do.
I know you were a champion on all fronts here in terms of getting the word about chronic pain and rewiring the system. And there's this platform, which I think is amazing, that you have on YouTube with close to 400,000 subscribers and videos with like over 1 million views. How do you explain the engagement you're getting on YouTube?
Yeah, I think just because there is a need. I opened this YouTube channel in 2019 because for my own patients, my desire was I want to educate my own patients on these topics, these concepts, and I don't have a lot of time during my clinic because we're always rushing. And I wanted them to learn. So I said, okay, I use my cell phone and then I record and put on YouTube for my patients. But then it exploded. A lot of people that are not I don't have already
400,000 patients?
No, I don't have 400,000 patients. But it's interesting that a lot of people watch my videos from Africa, Philippines, India, Vietnam, South America, and I hear the comments are so enlightening because they tell me they're learning so much about pain, chronic pain. They don't have these resources in their country. So I really, it touched my heart that the knowledge that I have in this little head of mine is touching so many lives around the world.
Well, what's cool is you're making science, and in this case, the issue of chronic pain very accessible to people, very understandable, which I think is terrific. Last question to you. How, you're a longtime advocate for a national pain strategy. How would this help in terms of addressing chronic pain in this country?
Yeah, so fortunately, the federal government has asked for a task force in Canada. So there was the Canadian Pain Task Force that finished a 3-year report and delivered this to the government, the federal government. But we need so much more because we need this concept of the mind-body connection. What do you do? What are the alternatives to medications? We don't have a lot of resources yet. Like I have to tell you, even in downtown Toronto, when I diagnose someone with this malfunctioning of the pain system, I have difficulty to find therapy for them. And a lot of people are disadvantaged. They don't have access to psychology or mental health. They don't have, sometimes they don't even have a cell phone or access to computer. So I wish I could have more access to mind-body therapies for my own patients. This would be a desire that I have because I know it works. There's evidence that it works. And can we train the pain system and actually go to the source of the chronic pain, which is the malfunction of the pain system, instead of giving them medications that just mask the symptoms, almost like putting a Band-Aid on the symptoms without treating what is underneath.
Thanks so much, Dr. Furlan. I'm going to bring you back in a little later for a discussion. A quick reminder to our audience, if you have a question for Dr. Furlan, go to the Slido page, the link's at the bottom of your screen, and you can type in the event code and submit your question. And remember, nothing of a personal medical nature. All right, let's bring in Dr. Dinesh Kombari. He's the director of the Schroeder Pain Management Center, a KITE senior scientist, and a clinician at Toronto Rehab. Dr. Kombari, welcome to the live stream.
Thank you very much for the invitation.
Great to have you here. Dinesh, first, let's talk about the Schroeder Pain Management Center. How does this center work together with Toronto Rehab and KITE towards the pain solution?
Well, I want to start off by thanking the Maria and Walter Schroeder Foundation for allowing us to pursue this. It's been a dream of mine in my 30-year career as a physician trying to help people manage their chronic pain. And really, I would say that it builds on the comments that Dr. Furlan made earlier. It has allowed us to create a platform for clinicians and researchers to come together And Toronto Rehab has generously provided us with a considerable amount of space to do this. So how it's going to help clinicians is we're going to be doing a very detailed assessment on all of the patients that are going to come through the Toronto Rehab pain program. And so a detailed report will be provided to somebody like Dr. Ferlin before she sees this patient. And so all of the various complexities that come, during an assessment by a physician of a patient, some of these will have the information in this report so that a pain physician can then concentrate on establishing rapport with their patients, understanding the problem a little bit better, and not be sort of burdened with collecting information. So that's one step. And the other is that we're going to establish a comprehensive multidisciplinary treatment program that fits into the current evidence-based model of care, which is the biopsychosocial model. So us as physicians are primarily practicing in that biosphere of the biopsychosocial. And so having other therapists, psychologists, occupational and physical therapists, social workers, and others to help supplement the care is one of my dreams, and we're going to have it come to fruition here in this platform. And this platform, the other exciting part is, and I think it'll really be the first in Canada that does this, it's going to bring clinical doctors together with basic science researchers. And it's going to meet the needs of both sides. So, for example, doctors seeing patients have these questions that arise. My goodness, I saw somebody with, this kind of issue. I really don't know the answer to that. What do you guys think? Can we do a little study that looks at this? And on the basic science side, these are experts in their field in various other faculties around the university, but they don't have access to the patients. So all of their fascinating results, in order for them to be applied to patients, we need that research to be done. And so providing their expertise in what they have done in their labs in the basic science side and bringing it to the patients and being able to apply those research principles to patients will allow us to advance the care of these patients ultimately. So
that's amazing. That's great.
Yeah.
Dr. Kombari, take us back. I want to deal with sort of the overlay of the pandemic the last couple of years and how this has impacted care. Take us back to March 2020 and the declaration of the pandemic due to the coronavirus. How did you and your team pivot to address the challenges of maintaining clinical care at the center?
This is a very complex topic. I can just say, as a physician working in the clinic, having direct contact with patients, as was the traditional model of care, became exceedingly difficult because of the pandemic restrictions that were imposed. So everything sort of went to the virtual care model. And with that came access, but also limited information that patients could provide physicians. And of course, the physical examination component is not able to happen. So people were making changes like, can you show me how your arm moves? And then you demonstrate all these arm movements and so forth, and make suppositions based on that. So a lot of changes occurred.
Is there been an impact due to the pandemic on research at KITE? Like, has the pandemic shifted your focus at all?
Yes. So I'm more of a basic science researcher. And the pandemic imposed restrictions did not allow us to see any research subjects for a very, very long time. And that got phased in after about 1.5 years, I believe. And Andrea can jump in and correct me if I'm wrong, because she was part of the committee that was, reorganizing and bringing back all of the research, slowly. Things are a little bit better now. We're able to do a little bit more research now, but the number of subjects that can come at one time is still restricted, again, because we're still in a pandemic situation.
Understood.
Yeah.
Are you able to share with us some of the leading projects you have in the pipeline in terms of research at KITE?
Yeah. Well, one of them is the development of this database. So the detailed assessment that I was talking about earlier, blending that with the clinical research platform, what we are doing is creating a database that will help both the clinicians and the researchers, systematically collecting information that's relevant for both. And we're about to go to adopting an electronic medical record system at UHN. And so this is yet another challenge, because the information we collect that's clinically important needs to be uploaded there. So that's one of the exciting projects. The other is we're trying to tackle this problem of pain and the fact that this is a non-specific word. Like, what does that actually mean when you say chronic pain? What's going on in the body, right? And it's a very non-specific term. Patients use all kinds of different words as adjectives to that, but their relevance to the actual problem in the body still needs to be explored. So what we're trying to do is develop biomarkers using somebody's blood, imaging techniques like ultrasound and MRI, and EMG. So this would be electrical signals that your muscles produce that we can detect by electrodes placed on the skin. And then creating a composite of all of that information. So what a patient tells you and these 3 other elements, the imaging, the neurophysiology, and what floats in your blood. And what we're trying to do with this is to be able to inform a doctor like Dr. Ferlin, well, these are the elements that are active in your patient. And so it's not just chronic low back pain anymore, it's that plus these mechanisms are at play. And so now she can say, okay, so I can personalize my care, and so the outcomes should be better. The amount of suffering time should also reduce. So this is some of the stuff that we have going on.
And I'm curious, are there changes to the pain treatment paradigm that we should expect or that you envision in the future?
Yeah, let me give you a patient example. So in my clinic, when a patient comes in to see me and they're complaining of pain that's been in their neck and along their shoulder for a long, long time, one of the elements that is consistently found is this idea that they're scared to move that area because they don't really understand what's happening underneath. There's a fear that they might injure themselves if they move inappropriately. So what I've been doing is using ultrasound to show them their anatomy. So it's a little bit of gel. You put the probe on the area that's painful, and then on a computer screen, you can see, okay, here's your skin, here's the muscle underneath, here's the bone. And then I can show them, see, look, it's continuous. There's nothing broken there. Your bone is not broken. It's not fractured. Okay, let's move a little bit now. So we'll do some simple movements with the ultrasound transducer still in place, watching that screen. And then they'll see the muscles contracting, releasing, and they get this sense of, okay, yes, there is the pain, but things do work underneath there. So it gives them this permission of being able to move, knowing that they're not going to harm anything inside. And so this whole hurting and harming can be decoupled. So that's one of the things that we plan to do in this new place as well, the Schroeder Pain Assessment and Rehabilitation Center. Yeah.
Very cool.
Yeah.
I want to remind the audience out there, if you have a question for Dr. Kombari, go to the Slido page, the link's at the bottom of the live stream, type in the event code and send us a question. Just before we get to those questions, I want to bring you both in, Dr. Ferland and Dr. Kombari, to talk a little bit about research and funding. I'll start with you, Dr. Kombari. You know the challenge of the funding model for Canadian medical research, and the bottom line is there is no base funding. You can't just turn to the Ministry of Health or even UHN. So for financing, I read recently actually where UHN Research had over 700 different groups funding its research projects in the last year. Talk to us about this critical role then of philanthropy in making this challenging financing model work.
I'll start off, and Andrea, please jump in at any time. There's you're so excited when you get a grant. The grant provides money for equipment, for assistance to help you perform your research, for the patients to come and do the participating that they are needed to do for the research, parking and all of those kinds of things. But we as researchers, we don't get that money. Now, you need to appreciate that in order to develop these kinds of research ideas, you need a team of very talented people from different walks of life. We need everyone from mathematicians, statisticians, clinical epidemiologists, biomedical engineers, doctors. You get the idea. None of them actually can get paid enough money to create a team that can sustain itself between a grant. So there's this period where, oh my goodness, now we have no money. But we have lots of expenses of our own, right? We have our car payments and our house payments and everything else. So what do? And philanthropy is one of the options that has truly filled the gap for this. It's been able to provide some sustenance for these teams to continue so that they can continue to grow and build. The other is, there are expensive pieces of equipment that are needed to do this complicated work. And a lot of granting agencies won't provide that. So, for example, in our area, on the 4th floor in TRI, we're going to be purchasing a very complicated microscope that looks at a particular tissue in 3 dimensions and able to look at the way that tissue works, so the metabolic activity and so forth. This is hundreds of thousands of dollars, and it's very, very difficult to get that using the normal peer-reviewed granting process, right? So that is something that the philanthropy has allowed us to do. And it's like that movie, The Field of Dreams. If you build it, they will come. And so that's what I have found, that once I'm starting to get the word out to my science colleagues, lots of people want to come and work there. So I have somebody from the Department of Kinesiology at the University of Toronto who's interested in helping us understand the nutrition of a chronic pain patient. Most people, as you can appreciate, don't move very well. They don't eat very well. And so it's kind of like an engine, right? If you don't give it gas, it's not going to work well. So we as doctors, when we sit across from a patient, we really don't have any way of figuring that out. So these researchers are going to help us by developing a breath test. So imagine you come into the clinic, you blow into a little device for about 30 seconds, and then the results will come back and tell the doctor what the state of affairs is. Are your muscles starving for energy? Is this one of the reasons that you just can't move, you know? And so there's a different solution for that than to just say, oh, this is chronic pain and that's why I don't want to move because I'm scared I'm going to hurt myself. So it's just to give you an example of some of the complexities that we face and some of the new information that we can provide through this center to allow the Dr. Furlans of the world to practice in the best manner possible and allow the patients to get better faster.
And Dr. Furlan, let's bring you in. I'm curious, do you have when you speak to donors, do you have an elevator pitch?
You always have. So just linking to what Dinesh said. So we work together in the same pain clinic. And I get these reports that Dinesh in the Schroeder lab prepared. So this morning I saw a patient and the patient came to see me for the first time, but this patient 2 weeks ago was at the Schroeder doing all of these assessments and I got a package. For me, my elevator speech is, now that I got all of this information, super exciting, Dinesh is helping me to diagnose. Is it more like a problem in the muscle? Is it more like a neuropathic pain? Is it more like the mind? We call this nociplastic pain, which is this pain that the pain system is malfunctioning because it's a neuroplasticity thing. My problem my elevator speech is, I need help to provide treatment for these people. And I also want to educate the next generation, these physicians who are in primary care, family doctors. You see, my part is more like the application of this knowledge and education of the physicians community, nurse practitioners, people who are out there seeing these patients. So the language that we speak in medicine is publications, article publications. In order for us to publish science, because if I come to a physician and I say, look, this mind-body therapies work for this kind of pain, they want to see the proof. And the proof is an article, is a publication, a scientific journal. And for me to do this publication and go out and start talking about the science, I need the same thing that Dinesh needs. I need the scientist time, I need the research assistants, I need to compensate the participants of the research. So research takes time, it takes resources, and without philanthropy, we can't do much because unfortunately, pain is not in the top priority of agencies like CIHR. Very little, if you look for the word pain, in all funding from CIHR is less than 1%. It's not so sexy. And when you combine with mind-body therapies, I want to do a study on hypnosis or mind meditation or retraining of the pain system. I don't know, these agencies, they don't look as this as so important. They prefer to see, instead of removing medications, they want to see studies that you give more medications or more therapy. Like removing medications doesn't seem so sexy. If I was proposing to trial a new drug, probably I would get more funding. But removing medications and teaching patients to take care of themselves is something that is not well funded. And pain, again, is not well funded in Canada. So in order to apply this knowledge, treat people better in our center, because the experience that I have is with the patients that I treat. But if I could do larger scale, multicentric studies then I think the clinicians community all over Ontario, Canada, and the world would pay more attention to what we are saying.
Well, hopefully sessions like today help get the word out and
Mhm.
show people that pain is actually, it's ubiquitous. It affects so many of us.
One of our desires, if I could just add
Sure.
to what Andrea is saying, is to be able to do this at our center and then take it to other centers and convince other doctors in Kingston and Ottawa and London, other places, that this is a really great addition to the way you're working now. And the information you get is so important that you'll really, really want to do it. It's still the field of dreams for me. So Andrea and I are going to work together with our colleagues at the pain clinic in TRI and KITE to publish and bring it to our colleagues so that everybody can, doctors will be more satisfied with what they're doing, patients will feel better faster, and there'll be less disability.
Let's get to some questions from people in the audience because we've had a bunch come in while you two have been talking. So let's go to our Slido page and I'll let you two arbitrate who should be answering what questions. First one from Pierre. In examining pain treatments and the fact that opioids can be very harmful and have addictive qualities, can you elaborate on the benefits of THC and CBD? How prevalent is this therapy in chronic pain? Andrea?
Yes, I can talk about that. The research for pain is not so exciting as we thought initially. We have some evidence that THC, not CBD, helps in some types of chronic pain. That's more like the neuropathic pain, pain caused by chemotherapy, or pain caused by HIV, which affects the nerves. For the general musculoskeletal pain, like low back pain, neck pain, we don't have a lot of research, and the ones that are published, they don't show really big effect. Again, because musculoskeletal pain is mostly what helps is movement, relaxation, removing mental stress, and physical, moving the body, exercises. CBD has some evidence that helps with sleep. So because sleep is a common comorbidity, then sometimes people use to help sleep. But again, it's not a panacea. Panacea means it treats everything. We were initially very excited that CBD and THC would treat a lot of things, but has been more disappointing lately that in our clinic, and when we reviewed the evidence, it doesn't seem to be treating everything. So I would say mixed effects.
Fair enough. Next question from Barbara. When help is not forthcoming in sorting out back and hip issues, to where can one turn? Does one live on Tylenol indefinitely?
Dinesh,
Dr. Ferlin?
Me? Okay. No, Tylenol indefinitely is not a good idea because that may damage the liver. That can cause a liver toxicity. Back and hip issues, again, there are a lot of things that could be causing that kind of pain. Could be the bones, could be the arthritis, the cartilage, the muscles around. And again, we need to examine the patient, and a good physical examination tells a lot. And with all of these assessments that Dinesh Kombari is doing in his lab, we are getting a lot of more information. So it could be that the pain is localized in the hip and back, but also it could be that the pain is localized in the pain system. And Dinesh is helping us to differentiate, is this pain coming just from the muscle, from the joint, or is it more the pain system that is malfunctioning? And then we would need to separate the treatments. And hopefully once we apply the right treatment, we will know if it worked or not. So I would not advocate for living on Tylenol indefinitely.
Fair.
If I can just add one thing to that, I think this is a very complex problem as well that needs an approach from a number of practitioners who can assess and manage pain. And Barbara, it's unfortunate that you've had such difficulty sorting out your problems, but in the ideal situation, a coordinated effort between your family doctor, pain management specialist, maybe an orthopedic surgeon, a rheumatologist, to get all of the information necessary to create the proper diagnosis. And then the treatment can come after that. I completely agree with Dr. Ferland that, Tylenol indefinitely is not a good solution. Actually, I would go one step further and say Tylenol is not actually a solution. It's a Band-Aid. You're just trying to suppress a symptom, i.e. pain, without actually knowing why. And so I would say have a coordinated approach. Maybe go back to your family physician and suggest this kind of approach. Maybe that will take you further.
Terrific. Thank you both. From Heather, would you please explain the role a sensitized nervous system plays in persistent chronic pain in general, and more specifically after COVID-19 infection? Thanks. Dr. Ferland, you want to take that one?
Okay. Yeah, so the sensitized, we know that the sensitized pain system, which is the acute pain that then transforms into chronic pain because the pain system is malfunctioning, there are a couple of things that predispose a person to have this, an injury, psychological trauma, previous experiences with pain, and infection. And we know that infection by a virus or some infection could be bacteria, but it's mostly virus, predispose a person to disrupt these pain sensations. Sometimes they develop chronic pain, but sometimes they develop a fatigue. It's a constant fatigue. It's different from being tired, because if you're tired, you rest and you feel better. This fatigue caused by post-virus syndromes, you rest, but then you don't feel less fatigued. This is what long COVID seems to be affecting. And there's a chronic fatigue syndrome that is described also in the literature. Yeah, so there is a role. Some people are more predisposed, and we know that the mental state also that the person was at the time of the infection also affects how much they will disrupt these pain sensations.
Terrific. Dr. Kombari, anything to add?
No, I think she covered it very well.
Good. I think somebody's computer has just crashed. We're waiting for our Slido page to come back up.
I think Kimberly's
just got one from the chat. Sure. Let me ask it this way. Hip replacement surgery is now going to be done on an outpatient basis with no overnight stay. How will we cope? We just lost that one. Okay, so we've answered Heather's questions. From Deb, hip replacement surgery. Sorry, I was just reading that one. It's now going to be done on an outpatient basis with no overnight stay. How will we cope re adequate pain control? Who wants to take that one?
Yeah, I like to take on that one because that is related to opioids. So the pendulum has gone too far. When we say opioids don't work for chronic pain, it also doesn't mean for all chronic pains. I have people on chronic pain that they need opioids because they have neuropathic pain, or they have a constant pain that is a normal pain, like acute pain. For post-surgical pain, this is the kind of surgery. I have seen this nonsense that people post-surgery don't need opioids because nobody needs opioid for pain. Really, that's the good use of opioids. If we need, not everybody needs opioid post-surgery. There are some people that they don't need. But if the person needs opioids, the good indication would be after surgery for a short period of time, 3-7 days, depending on the type of surgery. People with cancer-related pain, people with a trauma, like a fracture, they need opioids for a few days, maybe 1 week. So we should not be saying nobody needs opioids for pain. I think some people are going too far on the no side. Yeah, I think this is
Mhm.
There are other ways of adequate pain relief post-surgery, even Tylenol or anti-inflammatories. But if they need opioids for hip replacement, 7 days is really, it's not a problem. Nobody will criticize the doctor for giving them 7 days supply of opioids.
Next question. Some doctors are
Can I
suggesting.
add to that a little bit, Christian? Do you mind?
Absolutely.
Sorry. So, when we started off, patients used to be admitted for almost a week, and any sort of complication could be dealt with in the hospital. Then it came down to, less than a day. And there was a trepidation from the patient perspective, like, oh my gosh, who am I going to call if I have a problem? And Dr. Furlan's addressed one of the issues, that about pain, but patients who are at high risk because they have medical comorbidities are very closely monitored. And what we're doing at KITE is creating a tele-rehab facility wherein we will be able to contact the patient and the patient will be able to stay in touch with us so that we can appreciate the level of pain that they're having, as well as the amount of movement that they're gonna have. And there's an expectation after having a surgery like this that you're gonna remain, less mobile for this amount of time, and within a few days you're gonna be able to move about this much. And if people are falling off of that expected trajectory, then they have an immediate ability to be able to contact healthcare system and get plugged into the appropriate kind of assessment and treatment that they need. So there should be a reduction in the anxiety that somebody has that they're going home. Going home is a good thing, actually, because you can actually, in the hospital, unfortunately, there's infections that might be caught and various other things that can happen. So that's the reasoning behind this decision that people are going home a little bit earlier now, and the outcomes, how the hip heals, and everything are very, very good. They have not been affected by this length of stay reduction. So we need to keep it all sort of in context.
Next question. What do you do when multiple doctors won't listen to you or investigate the cause or causes of pain? How is a person supposed to advocate for his or her own health?
Yeah. Yeah,
Dr. Furlan?
that's why we're doing, I'm doing all of these echo programs and these online courses and YouTube, because I see this all the time. I am a pain specialist, so I love hearing people talking about their pain because I can help them. The problem is a lot of doctors are not trained how to help a person with chronic pain, so they don't know what to do. So they prefer not to hear that story because they really don't feel competent in helping people with chronic pain. And unfortunately, they will say the pain is in your head, and you must be imagining this because I did the X-ray or I examined you and I can't find anything wrong. But they have no idea about how to examine a person to see if the pain system is malfunctioning. So again, education. We are trying to train the next generation of physicians out there. Hopefully we'll do a better job.
Dr. Kombari?
I don't have anything to add. Very comprehensive answer. Thank you.
So probably have to be then our last question from Diane. Is lumbar radiofrequency ablation an effective management for sciatic nerve pain?
I will let Dinesh go first.
Okay. So pain that comes from the sciatic nerve is generally from an irritation of one of the branches as it comes out of the holes in the vertebrae. And this is a very severe nerve-like pain that starts in your back and goes down your leg in a particular territory. And the treatments for that are to, first of all, find out what the reason is for that pain. Generally, an MRI is done to establish whether there's a structural reason for that, like is there a disc that's herniated or something like that. When there's no such structure, but clinically this is still the case, then we have more esoteric causes, like maybe the nerve supply to that nerve has been impacted or so forth. So those need specialized investigation techniques. Radiofrequency ablation is not generally used for that kind of problem. There is a joint that's very close to the opening where this nerve comes out, and it's called the facet joint. And if that joint is irritated, then you can have pain that goes primarily in the back, but also down the buttock and partway down the leg. It's not exactly sciatic, but it's sort of pseudo-sciatic. That kind of problem is generally assessed by a detailed physical examination, then using an MRI to detect whether there is an abnormality in that facet. And if that is the case, in other words, the clinical scenario and the MRI sort of align, then what we would do is a diagnostic injection where some local anesthetic is applied to that facet joint to see what impact that has on that pain state. So generally, if you have more than 50% reduction in your pain from that kind of injection, then that's deemed to be a positive response. That is, that the correct anatomical location for the problem has been located. And so in that case, radiofrequency ablation may be considered as a treatment choice. Anything to add, Dr. Ferland?
No, your answer was very thorough. I would just say that I would never do lumbar radiofrequency ablation of the sciatic nerve.
Oh.
Yeah, because the sciatic nerve is a big nerve that innervates the leg, the thighs. So if ablation means cutting the nerve, reusing radiofrequency, which is a high frequency electrical current to damage the nerve. And if we do this in the sciatic nerve, you're going to be, your leg and thigh will not move. And so I probably the person did not mean the sciatic nerve. Probably they were meaning radiofrequency ablation of the nerve that innervates the joint that Dinesh was talking about.
Yeah.
I want to thank you both. We've come to the end of our time today. Dr. Andrea Ferland and Dr. Dinesh Kombari, both senior scientists at KITE and Toronto Rehab clinicians. Thank you for taking time out of your busy days to be with us today and give us your expertise and your vision.
Thank you for inviting me.
Yes, thank you as well. It's a pleasure to speak with everyone. Hopefully we helped out a little bit.
And I want to again, a big thank you to Mr. Robert Blakely, sponsor of these health innovation talks. And the UHN Foundation would also like to extend a thank you and acknowledge Walter and Maria Schroeder and the Schroeder Foundation and all of our donors in the community who are helping us change the future for those who suffer from chronic pain. And a thank you to you and our audience today. Thank you for being here. This event has been recorded and will be up on the UHN Foundation YouTube channel right after this live stream ends. And finally, if you're moved to donate to the groundbreaking work to improve patient care and find new treatments at Toronto Rehab's KITE Research Institute, you'll find a link at the bottom of this streaming window that will take you to our donation page, and your support is very much appreciated. That's it for today's live stream. We want to thank you and stay safe, everyone.